Good morning, everyone, and I'm just going to hand over now to Sam, who's going to present on inclusion health and share with us some of the work that the Queen's Nursing Institute is doing around homeless health. Welcome, Sam.
Thank you very much. So Debbie Kennedy contacted me specifically about the dual diagnosis presentation that's up on the Q&I website. So I will talk a little bit about that at the end. But I'm just going to give you a little bit of an insight into the homeless health programme at the Q&I. So I'm Sam Dawley-Smith. I'm the homeless health programme lead at the Q&I. I am a nurse. It's a slightly grand title because I only get paid to do that one day a week. But I'm also the nursing fellow for Pathway, the Pathway charity, which amongst other things sets up homeless hospital discharge teams around the country. I'm also the secretary of the London Network of Nurses and Midwives Homelessness Group. And I also do rough sleeping street outreach for Doctors of the World. And obviously the thing that sort of brings all of those jobs together is inclusion health. And I've been working in inclusion health, I guess, for about 20 years. And in terms of what inclusion health means to me, it's assertive outreach or enabling access to healthcare for any of these groups. And if you do a little bit of research, it comes to about 2 million people in the UK that come into inclusion health groups. So homeless people, prisoners, asylum seekers, illegal migrants. This is not deprivation. So Joseph Rowntree estimates that about 14 million people are in deprivation. And there obviously is a crossover between inclusion health and deprivation or deep end medicine. But I think it is important to know that we know that if you're from one of these groups, that your health outcomes are even worse than those living in deprived areas. And that's what this graph shows you. And that's our story, one of our clinical nurse leads who did a lot of this work. So this is specifically about homelessness because I know that's what you wanted to hear, and obviously there's a COVID context to that which we can bring into the discussion afterwards. But prior to COVID, homelessness has been increasing year on year across England since 2009, 2010, when it was at its lowest. And at the end of 2018, Shelter estimated that there were about 320,000 people homeless in the UK, but we know that that's gone up since. So the pre-COVID numbers in London, for example, were up about 1,200 on the prior year. And alongside that, we've seen increases in A&E attendances and in secondary care usage, admissions specifically. And we've also, alongside that, seen an increase in deaths. And some of you may know that the Office of National Statistics has now started to collate data from death certificates year on year, where the death certificate indicates that the person was homeless. And we've already seen an increase in that year on year. And indeed, last year there were some concerning trends around addictions and overdoses specifically. Just to say that when you get this presentation, all of these pictures have got links through to those articles. And you're probably aware of the very sort of common statistic that the average age of death of men who are street homeless anyway is about 47, and for women is 43. And there's two main causes of that. One is trimorbidity, so the co-concurrence of physical health, mental health and addictions problems, and often people have multiple conditions going on in the back, so there's a lot of complexity, but also barriers to healthcare are huge, and that's barriers to healthcare both in primary care and in secondary care, but I would say that access to mainstream GP registration and NHS charging have been really devastating in terms of disenfranchising people's access from care. And in terms of GP registration, that's actually got a lot worse during COVID. And there are sort of lots of concerns about what's called total triage and remote by default, but we could talk about that later. On the brighter side, though, inclusion health nurses are at the forefront of care delivery in this area. And those are three of our brilliant sort of nurse-led projects. And there are lots of clinical networks, obviously, but these three clinical networks are at the forefront of supporting nurses. So the Queen's Nursing Institute Homeless Health Network currently has 1,300 members, of whom about 700 or 800 are nurses. The Faculty of Homeless and Inclusion Health has about 2,000 members, of whom about 600 are nurses, and the London Network of Nurses and Midwives Homelessness Group has 225, of whom about 150 are nurses. I'm not going to talk about the other two because I was invited here through the Q&I, but the networks do very similar things. The Q&I produces newsletters, it produces clinical guidance on a variety of different issues, and I'm in the process of updating a lot of that. There are grants for courses. There's a number of specific networking groups, like, for example, health visitors working with homeless families or Gypsy Roma traveller boater nurses. The Q&I does innovation projects, and also I provide a lot of ad hoc support, particularly to people newly starting out or to lone workers, and that might be clinical guidance, or it might be networking them with other people around service setups or that kind of thing. Just in terms of the innovation projects, they run every year. In 2018, they specifically focused on nurses working in homelessness, and there are a number of projects in your patch that are in that, so click through and have a read. But the innovation projects are running again this year, and that's for applications on complex needs in primary care, so inclusion health would still be involved there. So just on to dual diagnosis, which was specifically how you came to me. In practice, a formal diagnosis is around somebody who's got a severe and enduring mental illness and a severe substance misuse problem, but it's used much more loosely than that. I suppose, I would also have some concerns about it because very few people have a dual diagnosis. Most of them have got complex needs, but I'm sure you know that. And we know that it's very common. So the percentage of people in substance misuse services with a mental health problem or vice versa is very, very high. I suppose a very key thing for this group is that suicide risk is much higher than if you've got substance misuse or alcohol problem, or mental health problem alone. So it's really important to keep that in mind. And we know that service users experience massive difficulty accessing treatment. Substance misuse is seen as an exclusion for mental health support, and there's a lack of belief that mental health support works for those engaged in substance misuse. And then if you add all of the different structural barriers around accessing care, it is really problematic, and you get into all sorts of difficult conversations about how the problem is attributed. And people feel that they don't have the training or abilities to manage the two together, and there's lots of different funding and commissioning streams, and it all gets incredibly complicated. And it won't surprise you to know that the most common mental health problem is personality disorder or complex trauma. And we know that services for that group are inadequate anyway, regardless if you've also got a substance misuse problem at the back of that. And lots of this group as well have brain injuries as a complexity. The brain injury either from head injury or more commonly from alcohol-related damage. And of course that causes memory loss, confusion, impaired attention, but all of those things that stop people from accessing care very well themselves without support. So St Mungo's, really big voluntary sector leader, did a report in 2019 showing that their belief was that around 12,000 people from our most disenfranchised groups were missing out on treatment on account of having a dual diagnosis, and this has been presented to APPGs and to government. The experience of the patient, of course, in that is pretty appalling, and I'm not going to go through that because I'm sure that you can imagine it, but there is a film of a patient's experience that you can click through there of explaining how it feels to be in that revolving door of trying to get treatment when you've got a dual diagnosis. And just to say that the problem isn't just around rough sleeping, it continues into all forms of homelessness, and this piece of work was around supported accommodation, showing very, very many of the same problems that people were having in supported accommodation. I'm not going to go through these, but just to say, if anybody's interested, obviously and you're probably very familiar with these anyway, the key documents that kind of say that all of those barriers shouldn't exist and how services should be delivered are in this Public Health England document and in the NICE guidance. And if you're a service lead, this is a really good quick guide for community nurses and other community staff on how to work effectively with people with personality disorder in the community if you're not a specialist. So click through to that, it's well worth a read. And then I suppose I just wanted to end on, this is not teaching my grandmother to suck eggs, but this is just to say that a biggest problem in homelessness and in dual diagnosis is mental capacity assessment. As we know, capacity fluctuates and it's situation specific, but obviously if I had £1 for every time somebody had told me that someone had got capacity, I'd be a very rich person. And I've always kind of like, for what, when, all of those kind of things. I suppose if you're a service lead, it's really important to note that these are the things that people leave mental capacity training with it in their brain. They leave remembering, assume that the person has capacity to make the decision. And they don't really focus on the last bit. They assume that the person has capacity to make the decision. And then unwise, eccentric or wrong decisions are not necessarily proof that they lack capacity. And they walk away with those in their mind, but they sort of miss point 2, which is as much help as possible must be given to help the person understand. And what happens in this group is that a lot of this group don't want to engage with the assessment. They say, why are you testing me? They might tell you to F off. There will be lots of barriers to undertaking the mental capacity assessment. And the problem is that people use that as evidence of the fact that they've got mental capacity, but that is not the correct interpretation. And obviously what we need to do is potentially have an MDT discussion, try again, take more time. And what I've found across the board is that training doesn't really cover this, and it doesn't unpick these situations and what one should do in this situation. And the only reason that I put that at the end is because if you look at safeguarding reviews, serious case reviews of people that have died who are homeless, time and time and time again, the thing that's been identified is that there's been lots of access for services, lots of time and opportunities to intervene. It sounds very similar to other things, doesn't it? But a key thing is that people don't really understand how to undertake a mental capacity assessment, and it's failed in these cases. So that's it. I was trying to leave lots of time for discussion. The Progress e-learning is around dual diagnosis, and it's very useful, and obviously the dual diagnosis journal is very useful. But that's it from me, because I'm hoping there's going to be quite a lot of questions and you're going to talk about what you're planning to do. Is that
My goodness, that was wonderful, Sam. That was extremely comprehensive. Thank you very much indeed. I found that fascinating. Can you just tell us a little bit more about the work of the Queen's Nursing Institute and how members can access the work you do or collaborate with you, please?
So the Queen's Nursing Institute is I think the oldest nursing charity. It's not a union. It's a supportive organisation, and what it's aiming to do is support nurses in practice and obviously encourage best practice in community nursing. In terms of all of the networks that I put up, and indeed many more, they're all free to join. Anybody can access them. In terms of individual tranches of work that are undertaken by any of those organisations that are specific quality pieces locally, obviously they would need to be funded individually, but there is core funding for sort of one-to-one support. So if somebody is just coming in from Cornwall and they're a lone worker and they need support or whatever, we would do that. If it was more system-wide change, then it probably might need to be funded separately. Does that answer the question?
It does, thank you. Does any of the network have any questions for Sam? Oh, Sarah Jeffrey.
Sorry, really struggling to get my mute off there. I do apologise. Hi, Sam. That was really, really interesting. Lots and lots of information in there. Masses. We'd have to go back and look at it in more detail. I suppose one of the things I picked up on it, I'd be really interested to hear more about the pathway team's help with homeless hospital discharge processes. As a key, I work for Hampshire County Council. I commission the social inclusion services across the county, so the homeless hostels, etc., in partnership with district borough councils in Hampshire. The homeless hospital discharge, and I've got a few meetings. Obviously, I'm involved in social care aspects as well in terms of hospital flow at the moment, which is key. There is still some real challenges in terms of meeting the hospital discharge, the requirements of the new hospital discharge guidance, and taking into account people's individual circumstances in terms of homelessness. Just very interested in that area of work.
Sure. So I wasn't invited here by a pathway, which is why I didn't cover that in depth. And I can certainly talk to you separately about it. There are 12 so-called pathway teams around the country. But there are also a number of other homeless hospital discharge interventions around the country. The difference between the pathway teams and the others is that the pathway teams are clinically led. And they have a multidisciplinary team which includes an in-reach community specialist GP. So generally the GP from wherever the homeless practice is locally is providing 1 or 2 sessions a week, and then there'll be perhaps a nurse and an OT in addition to the housing workers and care navigators. Whereas in a lot of other areas it might just be a housing worker and care navigator. It is a clinically focused intervention, so we are building on hospital discharge, and what we're trying to do is maximise the benefit of the admission. So we're trying to use that admission not just to get someone housed, but to make sure that all of those barriers to primary care have been brought down, and that we've maybe got somebody in touch with peer support, and we've done all the screening that they need. But please do get in contact with me, and I can provide you all of the information about that. I would say that pathway teams are most effective as well when they are connected with specialist step down, because we know that intermediate care isn't generally available to our clients. They just sort of don't fit, and that obviously that recovery and recuperation is part of stopping the revolving door. So specialist units for that can be really helpful. Lots of evidence to say that the pathway, and indeed all hospital discharge interventions, save money. But having said that, it's not about saving money. It is about delivering quality and equitable service.
That's brilliant. Thank you. I may well contact you again. I just think it's a key area that we're looking at the moment in Hampshire, and the challenges, as I think across the region, continue there. So thanks. That's really helpful.
That's all right. Your nearest services are, well, your nearest service, pathway services in Brighton, I guess, is it? And there's just about to be one set up in Bournemouth.
Oh, is there? Okay, that's interesting. Yeah. Okay.
Do you know Maggie, the doctor? So we could put you in touch with the team that are coming into place in Bournemouth, and perhaps you could talk to them.
That would be fantastic, because I think, in our hospital discharge workers across the council, we do have admissions from Bournemouth, and we are linked in there. So I think it'd be really good to hear what's going on there. It's fab. Thanks.
Okay.
Thank you, Sarah. Sam, are you comfortable if we share your contact details with the network after today?
Yes, of course, yeah.
That would be great. There's a question in the chat box from Rose Hawkins. She asks a bit left field question, but from your experience, does domestic abuse and specifically coercive control get covered in mental capacity training in terms of whether a person is safe enough to make their own choices?
Not really, no. I mean, I find that, so my experience of the mental capacity training is that it isn't very good at applying it to scenarios. It very much focuses on the law. And what would really benefit, say, if your leaders in training, is for it to be taken from from a case study focused perspective. Actually, in terms of, I mean, I'm sure you know this because it's been in the news a lot, but all of the pathway teams have seen an increase in domestic violence, but in the network of health visitors working with homeless families, where they've had to move online and do all their stuff by Zoom. I think they've had massive challenges, I think, with people that they're worried about with domestic violence, because obviously they can't see people off screen, and just being in the environment is so it's so reassuring in terms of understanding your assessment. So domestic violence is really important. No, I don't think it's covered properly.
Can I just ask, are there good training sessions available that you're aware of, Sam, around the mental capacity?
So we've talked to Kenny in NHS Safeguarding about this, that it needs doing properly, and we've contributed to training and putting in scenarios. To be honest, you're reminding me, I don't know where that's got to, so I will contact Kenny Gregory after this and find out where it's got to, because there is, the national NHS safeguarding training, and I say they were committing to do something about that. So I will check and get back to you.
That would be great. Thank you.
Yeah.
Does anyone have any more questions for Sam?
Is there Chris Giles?
Oh, well done. Yes. Chris,
Yes.
do you want to ask Sam?
Hi, Sam. Just like to say that was a great presentation. Thank you very much for sharing that. My question is there a sort of a source of evidence to show the cost benefits of medical interventions strictly for homeless people? I ask because we have a homeless nurse at the moment, and the CCG are deciding whether or not to continue with it. So it'd really be good to have something I could say, look, this is clear evidence that you will, as a CCG, save money by retaining this post. Okay,
so the first thing I would say to that, and I'm really, really happy to come and deliver it with you, is that, if the only reason you are going to commission services for any inclusion health group is to save money, then that's discriminatory and it's against the Equalities Act. And, that conversation should not be going on. I mean, I know, I understand the economic context of it, but they need to be encouraged to think about exactly what they're saying. Equitable access is vital, and it shouldn't be based on cost. And if we think about things like palliative care, and just it's really, really important. And I think we've sent ourselves down a rabbit hole because we spent a lot of time doing, this kind of work. And I think it's encouraged a conversation that's inherently wrong. There is, there's lots of evidence showing that these kind of interventions reduce A&E attendance and reduce admissions. Whether that covers the cost, and I can send you some, whether that covers the cost of the post per se, I mean, that's really, that is quite hard to say overall. Does that answer your question? It doesn't really answer your question. Does it answer the question? I mean, so I can send you stuff, but so do be careful. I think because as soon as you engage in that, I think we ourselves have got a responsibility to stop that conversation.
I completely understand what you're saying, and thank you very much for your answer.
Yeah, but I will send if I if you give me your email address, I can send you what we've got. You know, so but just be careful.
Great, thank you very much, Sam.
There's a hand up from Olivia.
That's right.
Yes, hi, Sam. Thank you for my Wi-Fi is pretty poor today. I was just going to respond to Steve to say I went through the same thinking about what will make my leaders within the Southeast region of NHS England improvement understand that this is not just the right thing to do. There are different statutory, moral, financial imperatives. So I think what I came down to, Steve, is that there are the legal requirements around, and especially for CCGs and NHS England, in decreasing inequalities in access and outcomes. So that's a statutory requirement. In terms of financial impact and also interventions, I put side by side two slides, one that showed the average life expectancy compared to the usual life expectancy, and then the cost per adult in terms of care. So we know that a homeless person costs 4 to 5 times more. So if you put side by side the cost and the output, if you don't do something, actually as a system, not only are you not doing the legal or the moral thing, but you're also just storing up more problems. So I think that there are ways to say this is a really high impactable cohort, and if you do I always say a triangle of, you know, your most vulnerables and your highest needs, and you invest at the top of the pyramid, then you should generate benefits, whether in kind in terms of impact on all the public services or eventually financial impacts. So it's trying to find the ways that make your leaders with competing agendas in terms of finance and legal obligations see that there is actually a logic in supporting that group.
Yeah. Can I just, I trailed off because I was thinking, what else was I trying to say? The problem, Chris, with the cost benefit thing is that the cheapest homeless person is a dead one. And so when you think that the average age of death is in rough sleepers is 47 and 43, the reality of it is, you know, if we intervene and we support them and whatever, actually ultimately it is going to cost money. They've got complex needs, getting them into treatment and all of those kind of things. But you know, to say that if you're not going to do it and they're going to die, and unfortunately there's nobody advocating for them. You know, we need a confidential inquiry. There's nobody there saying this is outrageous, this person that died at 43. So you do have to be that. Those are the kind of things that need to be got across to the commissioners when they're going through those kind of arguments. Anyway, sorry, that's me on my soapbox. Is there any other questions? Just to put some COVID context, I suppose. So I've been working in the hotels for 3 months in the Everyone In programme. Obviously, I mean, I'm sure all of you will be aware of this. There's lots of changes in the dynamics of homelessness locally, and we don't know what will happen. And the Everyone In programme has been incredibly successful at stopping infection and death in the homeless population across the UK. So that's one thing that we can say is really successful. As far as we know, we've only had 16 deaths attributed to COVID in the homeless population across the UK, and only 6 in London. So that's really good. Conversely, there may be a lot of missed opportunities. So lots of people have been brought in and, and have settled well. And, we would like it if none of those people went back onto the streets ever. The word on the street is that as the funding for those hotels and provisions is running out, is that we are now seeing a drift of people back onto the streets, and it's deeply concerning people because at the moment, night shelters, there's a very strong recommendation that night shelters won't be able to open or shouldn't open. and you will have noted, I'm sure, the sudden change in weather. So that is a massive concern for homeless health services across the country as to what's just about to hit, and obviously what will be the impact on inclusion health services, but also potentially on secondary care as well.
Yes, I think you've highlighted a concern that we're going to come on to later in this meeting, because certainly that's PHE's advice hasn't changed, that night shelters need to remain closed. But in terms of preparing for winter and second surges, we do have to take into consideration what happens during the winter months. And there's a feeling that the faith sectors will certainly push for some form of opening to care for those people who are struggling. So we will look at that as part of our network, Sam, for sure.
Okay, so I know this is the end of my bit, isn't it? Was there any more questions? No. So I'm getting in contact with Chris and Stephen. Is that right? And
yes. And I will put your details in a follow-up email, Sam, so that if on reflection or people who watch the webinar afterwards need to get in touch with you, they can do.
Yeah. Okay. Well, thank you very much for having me.
You're very welcome. Thank you for joining us this morning.
And enjoy the rest of your meeting.
Thank you so much, Sam.